Good morning, good afternoon, everyone. Thank you for joining me in this educational session. My name is Richie Lazaro. I'm the regional pathologist in the non-commercial division of Medical and Scientific Affairs at Roche Diagnostics Asia Pacific, based in Singapore. Thank you for this opportunity for me to speak about mismatch repair immunohistochemistry and how deficient MMR is significant in solid tumors. I'll cover MMR background, the Ventana RxDX immunohistochemistry panel, scoring algorithm, and share some images along with interpretation challenges. So as a simplified background, in our DNA replication process, errors sometimes occur in the form of point mutations or insertion deletion loops. Mismatch repair proteins, which are ubiquitously present in proliferating cells, are essential in the DNA repair process. There are at least 7 MMR proteins in humans, of which 4 are most clinically relevant in cancer biology. The MSH2 or mut-S homolog 2, which forms a heterodimer with mut-S homolog 6 to bind to the base mismatch, and recruits mut-L homolog 1, which forms a stable heterodimer with post-meiotic segregation 2 or PMS2, which together initiate downstream repair events. In an proficient MMR repair process, this generally results in stable DNA strand repeats, or what is called microsatellites. If there is any defects in any one of the DNA MMR genes, be it germline and or somatic mutation, or a somatic inactivation of MLH1 caused by promoter epigenetic hypermethylation, leading to the loss of the MLH1 protein. This leads to the loss of expression of the MMR protein, resulting in microsatellite instability. The loss of MMR function resulting to MSI across the genome can affect genes nearby, and if not corrected, when the mutations occur in key oncogenes and tumor suppressors, this leads to dysregulated cell proliferation and or cell death. Now, MMR is not a new biomarker, and it has been used in routine practice in colorectal cancer as per international guidelines to rule out Lynch syndrome, previously called hereditary non-polyposis colorectal carcinoma or HNPCC. Lynch syndrome is an autosomal dominant condition with accelerated carcinogenesis, increased risk of cancers, especially colon and endometrial cancer, and the clinical background, including young age of the patient, family history of multiple cancers, and the suggestive colorectal histology that includes the presence of tumor-infiltrating lymphocytes, Crohn's-like lymphocyte reaction, a mucinous or signet ring differentiation, or the medullary growth pattern. In clinical practice, as summarized in this review article, the MMR panel includes the BRAF V600E immunohistochemistry to distinguish between a probable Lynch versus likely sporadic colorectal cancer in tumors with loss of MMR protein, typically the MLH1 and PMS2 combination. And if BRAF immunohistochemistry shows cytoplasmic staining in a tumor where MLH1 and PMS2 show loss of nuclear expression, as shown in the image on the right, the colorectal cancer is considered clinically sporadic and would not need germline testing to confirm Lynch syndrome. Most colorectal cancers are sporadic and only 3 to 5% have Lynch. And for patients with Lynch syndrome, family members are advised earlier and increased cancer screening and genetic counseling. Aside from counseling family members, deficient MMR helps stratify sporadic versus heritable colorectal cancer because management and surveillance may differ. It is associated also with more favorable prognosis and do not benefit from 5-fluorouracil-based adjuvant chemotherapy in stage 2 cases. More recently, deficient MMR may predict response to PD-1, PD-L1 checkpoint inhibitor immunotherapy. Because MMR deficiency is now observed in many solid tumors and is most common in endometrial and gastrointestinal cancers, recent guidelines now recommend MMR testing on solid tumors as predictive marker for immunotherapy. Now, MMR mutations have implications in the interpretation of MMR immunohistochemistry results. Frame shift mutations are more common, and the destabilized protein is lost in the nuclear membrane, which is demonstrated as a loss of nuclear staining on tissues in immunohistochemistry. Missense mutations are rare, but it's important to note that these may alter the function of the MMR protein because the nuclear expression and antigenicity are retained. Thus, MSI testing using PCR or sequencing can complement MMR testing in this scenario, especially if there is strong suspicion of Lynch or Lynch-like syndromes based upon family history or clinical characteristics. Now, approximate incidences of mutations in commonly mutated MMR proteins in colorectal cancer include a majority of mutations in MLH1 and MSH2, followed by MSH6, then PMS2. Now, 3' epithelial cell adhesion molecule mutation can also lead to subsequent somatic hypermethylation and loss of MSH2 expression in some cases. MMR protein expression loss patterns observed for deficient MMR are as follows. It's usually seen to occur in pairs. For example, loss of MLH1 protein expression is accompanied by the loss of its binding partner PMS2. And loss of MSH2 is accompanied by the loss of its binding partner MSH6. And because MLH1 and MSH2 can potentially bind to other binding partners, either PMS2 or MSH6, which exclusively binds with MLH1 and MSH2 respectively, can also have isolated loss of protein for either of the PMS2 and MSH6 biomarkers. Let's talk about Ventana immunohistochemistry for MMR. So deficient MMR now serves as a predictive biomarker for immunotherapy. And very recently, FDA has approved Ventana MMR RxDX to identify deficient MMR in solid tumors and as a companion diagnostic for proficient MMR endometrial cancer. Now, deficient MMR correlates with higher expression of PD-1 or PD-L1, possibly due to increased neoantigen expression associated with tumor mutation burden that results from replication errors. For endometrial carcinoma patients with proficient MMR, PD-1 inhibitors may retain activity when combined with a tyrosine kinase inhibitor. Here is an example of the Ventana MMR panel showing proficient MMR. And this is demonstrated by the 4 biomarkers MLH1, MSH2, PMS2, and MSH6 exhibiting nuclear expression in both tumor cells along with stromal cells also serving as internal positive controls. And both should be correlated in every case. And we'll explain more about that later. Along with the antibody slides, there would be a negative control slide to rule out any background staining and validate the staining process of the 4 biomarkers. Of course, an H&E slide would be essential in correlation with the IHC. Pre-analytical considerations include fixation in 10% neutral buffered formalin for no less than 6 hours and no more than 72 hours. Zinc formalin and alcohol fixatives are not recommended. Section of tissue thickness should be at least 4 microns and mounted on positively charged slides. The assay should not be performed on cut sections that have been stored longer than 45 days, as antigenicity may diminish over time. As you can see on the image on the right, where an experiment has shown different times of storing cut sections from 4 weeks to 10 weeks, and you can see that the 4 biomarkers can potentially show diminished staining with longer stored slides as it stands from 4 weeks to 8 to 10 weeks, especially for MLH1 and PMS2. Whether or not the slide is evaluable or non-evaluable, the following criteria are to be observed. It is evaluable if the H&E shows at least 50 viable tumor cells. The negative reagent control slide should not show any background staining, and it has to be acceptable in appearance. Morphology and background are acceptable. And most importantly, the internal positive controls or the stromal cell nuclei must have unequivocal staining. The slides will not be evaluable if H&E has less than 50 viable tumor cells. The negative reagent control slide, morphology, and background are unacceptable, and the internal positive controls do not have unequivocal nuclear staining. Or if the interpretation is not possible because of tissue loss or tumor absence, of course, and artifacts. Let's talk about the scoring algorithm. So this assay is scored as either intact protein expression or loss of protein expression. So for all biomarkers, MLH1, MSH2, MSH6, and PMS2, there should be a demonstration of nuclear expression by the tumor cells to be compared with the internal control positive cells, which are the stromal nuclei also exhibiting acceptable staining. And this would be called intact protein expression. If there is absence of nuclear staining on the tumor nuclei in comparison to acceptable positive staining by the stromal cells in the background, in the vicinity of the tumor, this would be categorized as loss of nuclear expression or loss of protein expression by whichever biomarker. And here are the images demonstrating intact versus loss. So elaborating on protein expression interpretation, in the interpretation guide, they would say intact expression is when there is unequivocal, straightforward, clear-cut nuclear staining in the viable tumor cells in the presence of acceptable internal positive controls. So what comprises acceptable internal positive controls? This would mean nuclear staining in the lymphocytes, the fibroblasts, or normal epithelium in the vicinity of the tumor or in the stroma adjacent to the tumor in question. Now, loss of protein expression and is when there is unequivocal loss of nuclear staining or focal weak equivocal nuclear staining in the viable tumor cells in the presence of acceptable internal positive controls. Now, in interpreting MMR status, it's either called proficient MMR or deficient MMR. Proficient is when all 4 markers in the panel exhibit intact nuclear expression by the tumor cells and the stroma cells. Deficient MMR is when at least one marker in the panel exhibits loss of nuclear expression by the tumor cells in the presence of positively stained internal control cells. So as mentioned, internal controls are very important in the interpretation. As you can see pointed out by the blue arrows, the strong fibroblast staining serves as internal control in this case of MLH1 and MSH2. And MLH1 is showing absence of tumor nuclear staining. So there is loss of MLH1, but there is intact MSH2 in this particular example. In this endometrial adenocarcinoma, you can see that there is absence of tumor cell nuclei staining, along with absence also of stromal cell staining, which would serve as internal controls. And if this scenario is encountered where the internal control cells are not staining, the staining should be repeated, as this is a non-evaluable or invalid slide. So in this case, repeat staining is recommended. Example of colorectal cancer with intact MLH1 is shown here. Colorectal cancer with loss of PMS2, and you can see benign mucosa serving as internal control on the image on the left. And you can see on the image on the right, the stromal cells do exhibit weak to moderate nuclear staining, serving as internal positive control. This is an acceptable staining appearance. Colorectal cancer with loss of MSH2, note that there is mild cytoplasmic blushy staining, which is to be ignored in the interpretation of MMR status. This is still an acceptable and evaluable slide. Colorectal cancer with intact MSH6. Colorectal cancer with intact MSH2. And I emphasize that the internal control staining would be acceptable. And in comparison, typically the carcinoma cells would either be similar in staining intensity as the stromal cells or darker. Colorectal cancer showing loss of MSH2. Same loss of MSH6 in this case. Example of sarcoma with nicely staining nuclei by the spindle cells in the presence of internal positive control cells. In this case, it would be the endothelial cells and in the blood vessels. Same cut of sarcoma for PMS2 showing intact expression. Urothelial carcinoma where MLH1 is showing intact status. The same specimens stained for PMS2 showing intact expression. Another case of urothelial carcinoma where MLH1 shows loss of protein expression. Endometrial adenocarcinoma showing loss of PMS2. Here there is some blushy, mild cytoplasmic staining and maybe a hint of membrane staining as well. As mentioned, these staining are disregarded in the interpretation of MMR. Some interpretation challenges. Non-specific background staining can happen for reasons that are not well understood. And for this reason, it is recommended to include a comparison of the slide to the negative reagent control slide to determine the level of non-specific background staining. If there is any cytoplasmic staining, this is disregarded in the MMR interpretation. Example of cytoplasmic staining that's very mild. This can frequently happen, but it's still an acceptable and evaluable slide, in this case, showing MSH2 loss of protein expression. In this case of MLH1 and PMS2 staining, the MLH1 is showing very clean, very straightforward, intact expression. PMS2 is also showing intact status, except that there is very dark cytoplasmic background staining, which is still acceptable and does not detract from the MMR interpretation, in this case of intact MLH1 and PMS2. Now, melanomas can be dirty looking, including the negative reagent control slide where the melanin pigment is diffusely present. But in this example of MSH2 and MSH6, the nuclear staining are still appreciable. So this is intact status. Papillary thyroid carcinoma showing intact status for MSH2 and MSH6. Now, colloid can sometimes have dab trapping, which is still acceptable and ignored in the interpretation. Now, focal staining may be seen in the tumor cells, and the staining intensity may vary from weak to strong. Sometimes this is due to variable fixation. Cases of treated specimens or where neoadjuvant therapy may produce weak or focal MMR staining in resection specimens, especially for MSH6. Now, this weak or focal MMR staining in treated cases does not reflect deficient MMR. Now, focal unequivocal staining seen in the tumor in the presence of appropriate internal control cells should still be considered as intact protein expression. And based on the scoring algorithm, focal weak, equivocal, or questionable nuclear staining in the viable tumor cells in the presence of appropriate internal positive controls should be categorized as loss. And I'll show you some images. So here is colorectal cancer showing very focal, intact expression by MSH6, whereas the rest of the tissue is showing absent nuclear staining, even if the positive, the stromal cells are showing positive nuclear staining as internal controls. Now, this is still called intact, but if there is question, especially in correlating with the clinical history of the patient, and if you are in doubt about the MMR status or even the MSI, one can opt to repeat the staining in another block or another specimen from the same patient, repeat that staining, or subject the specimen to MSI testing using PCR or sequencing as a confirmatory method. Now here in case of endometrial adenocarcinoma, there was focal staining by MSH6, but as mentioned, this is still categorized as intact status. In this example of focal staining, the nuclei are patchy in the very mild staining in the glands in the adenocarcinoma. In comparison, the internal control cells are showing acceptable nuclear staining, which is darker and very straightforward. Now, in this case of patchy focal weak staining by tumor nuclei, significantly weaker in staining intensity than the stromal cell staining, this is categorized as loss status in this example of MSH6. Another example of very mild or very weak kind of blushy nuclear staining by the tumor cells in the presence of acceptable internal control cells. This is categorized as loss status in this example of MLH1. Now, aberrant staining patterns include punctate or dot-like nuclear or cytoplasmic staining, where the staining intensity may vary from weak to strong. There's a staining pattern called speckling, which is finer, more granular in appearance, that can be focal or can happen across many of the tumor cells. And the staining intensity may vary also from weak to strong. Very rarely, the nuclei may show membrane staining or nucleolar staining only, um, but the entire nucleus per se is not uh, having the stain. So in these staining patterns, when this is seen, this should be ignored. And if the case has only any of these types of staining pattern by the tumor cells, it should be given a clinical status of loss. So here's an example of how punctate or dot-like staining might look like. In this case of MLH1, the punctate dot-like stain is appearing in the nucleus or in the nuclei of the tumor cells in the presence of acceptable stromal cell staining. In this case, the category is loss status in this example of MLH1. Here, the specimen was stained for MLH1 and PMS2 in the images. MLH1 showing very clean, absent staining by the tumor cells. PMS2, on the other hand, has speckling as an aberrant staining pattern in the cytoplasm. So the speckling is ignored. The tumor nuclei of PMS2 is still showing loss of protein expression. So this is, both are categorized as loss status in this example of urothelial carcinoma. In this example of gastric adenocarcinoma, there is focal nuclear membrane staining in few of the nuclei. In this example, the focal weak staining by nuclear membrane is ignored and not included in the interpretation. In this example, the category is loss status for MLH1. Some artifacts include fixation gradients and edge effects, tissue cautery, artifact dab trapping, nuclear bubbling, or lack of staining in some areas of the tissue showing heterogeneous staining. Usually it's because of the variable fixation of the specimen. So if the staining is equivocal or you are not sure how to interpret the staining, one might repeat the staining process using another block or specimen, or it's possible also to opt for MSI testing using PCR or sequencing as a confirmatory method. Now, if the slides lack staining of the internal positive control cells, or if they show excessive background cytoplasmic staining or other technical artifacts that distract from appropriate interpretation of the nuclei, this may prompt repeat staining. So here's cautery artifact where we do not score in these areas. We do not score also in areas of necrosis. But in this example of MLH1, PMS2, and MSH2, in urothelial carcinoma, one can still appreciate intact protein expression for all three markers. Here's an example of tissue gradient in a case of HCC, where MLH1 is showing intact expression along the edge, but diminished staining in the middle of the specimen, where it is away from the fixative. So in this case, it is still categorized as intact status based on the fixed portion of the specimen, which is at the edge of the tissue section. Now, showing in blue arrows is how internal positive control nuclei might appear as acceptable staining in this case of HCC. And these internal positive control cells may be tiny spindly cells in the background adjacent to the tumor cells. Now, before I end, I wish to point out that the College of American Pathologists website now has released guidelines for MMR and MSI testing, which I did not elaborate in my talk. I'd encourage that we could just check this out and review the summary of recommendations. Thank you very much for your kind attention. This ends my lecture.
Cảm ơn cô Richie đã có một bài báo cáo rất là hay. Sau đây có những câu hỏi thì tôi sẽ đọc tiếng Việt cho các bạn nghe. Câu hỏi đây được đặt bằng tiếng Anh thì sẽ đọc tiếng Việt. Cô Richie, cô sẽ thấy câu hỏi tiếng Anh rồi, cô sẽ trả lời và bác sĩ Diễm sẽ dịch lại cho mọi người. Câu thứ nhất là người ta hỏi là cách đánh giá thế nào protein MMR trong cái tình trạng dương tính giả.
Hello again, Richie. So please answer the first question. Thank you very much for your wonderful talk. So the audience asked you about evaluation of MMR protein. Is any condition of false positivity condition?
Okay. Good afternoon. Thank you for this opportunity to share about MMR. So the question that I'm seeing is there any condition of false positive MMR, for false positivity, or maybe, falsely intact MMR expression? I think that would be the question as I understand it. To be honest, from literature, it seems rare, but it can happen. And as mentioned in my lecture, it depends on the type of mutation that happens in the MMR. Majority would be frame shift mutations, for example. But in the case of a missense mutation, which can occur, but it's rare, the MMR expression remains intact, but the MMR protein is actually non-functional. So it could appear as focal staining, or maybe weak staining, or maybe a bit of an equivocal staining. But it takes a lot of clinical correlation in this scenario, especially if Lynch syndrome is being suspected, or if there is a consideration to do immunotherapy. In cases where there is question as to the MMR status, if a false positivity is suspected, it's helpful to test to confirm using MSI, for example, or repeat the staining in another specimen. But this is rare. Yeah.
Thank you very much for the answers. I would like to translate. Với câu hỏi thứ nhất là có trường hợp nào thì những cái việc mà tồn tại của MMR protein là toàn vẹn, tức là không có biểu hiện âm tính cho đột biến MMR hay không, thì cô Richie trả lời là có, nhưng rất là hiếm và được báo cáo trong y văn. Tuy nhiên cái trường hợp này có thể liên quan đến cái loại đột biến, ví dụ như là đột biến dạng dịch khung, tùy loại, và liên quan đến đột biến dịch khung là chính, và có thể biểu hiện của MMR trên protein có thể sẽ là focal, tức là một phần thôi, khu trú, hoặc là biểu hiện không rõ và khó giải thích. Tuy nhiên thì chúng ta có thể xác nhận lại cái việc này bằng cách chúng ta dùng một cái mẫu khác của bệnh nhân đó, hoặc là chúng ta lặp lại cái thí nghiệm, và chúng ta có thể dùng cách khác, ví dụ như là sequencing hoặc là chúng ta PCR để chúng ta xác định lại cái việc là cái biểu hiện của nó vẫn còn hoặc là mất, để mà chúng ta xác nhận lại cái biểu hiện của MMR bình thường không bình thường. Nhưng mà tôi nhấn mạnh lại thì cái trường hợp này rất là hiếm. So please let's move on to the second question. In cases of carcinomas, is there any recommendations to evaluate?
Đọc tiếng Việt, khỏi đọc tiếng Anh. Cô thấy rồi.
Anh đánh vô câu hỏi vô đây được không?
Yeah. Okay. Please be quite sure that you see the questions, right? So I will translate the question into Vietnamese that people can follow up. Trong trường hợp carcinoma thì có một cái lời khuyên nào hoặc là cái guideline nào có thể là hướng dẫn cách đánh giá protein MMR trên thành phần nào của khối u hay không? Ví dụ như là đánh giá trên thành phần xâm lấn hay là tại chỗ, hoặc là cái vùng tiền xâm lấn thì nó sẽ tốt hơn. Xin giải thích và cho chúng tôi biết ý kiến của Richie. Please answer the question.
Yeah, so for question number 2, right? What part of the tumor will we interpret MMR? In my practice and in my opinion, I will evaluate all tissue, including benign areas. The MMR protein can even be lost in non-neoplastic mucosa. So of course, the tumor is the area in question, whether it's the invasive or the in situ components. I will evaluate in it. But there are studies that show that if there is absence of MMR in the non-neoplastic mucosa, it may potentially also suggest Lynch syndrome. I don't recall the article and the author, but I'm sure if you look online, you will find that this has been published. Although in general, I guess what I'm saying is when it comes to MMR evaluation, yeah, the entire tissue can be evaluated in a proper context. But of course, when it calling intact versus lost, it's the tumor itself, the neoplastic areas, and it will include invasive and in situ components.
Xin dịch lại câu trả lời của cô Richie, đó là trong thực tế thì khi đánh giá trên mẫu bệnh phỏng thì tôi sẽ quan sát và đánh giá khảo sát toàn bộ mẫu của bệnh nhân, cả vùng lành tính lẫn vùng ung thư, cả vùng ung thư xâm nhập và ung thư tại chỗ. Bởi vì trong trường hợp mà hội chứng Lynch thì có bài báo cáo người ta đã xác nhận được là có thể nó sẽ âm tính ở vị trí mà không ung thư, tức là trên cái phần biểu mô bình thường lành tính, và nó sẽ mất biểu hiện của một số gen protein. Vì vậy mà có thể sẽ gợi ý tới hội chứng Lynch, thì thế chúng ta sẽ có một cái cách nhìn nhận nó tổng quát hơn. Xin lỗi là tôi không có nhớ chính xác cái bài báo này, tuy nhiên thì bạn có thể tìm thấy bài báo nói về cái việc đánh giá này nào, chúng ta đánh giá toàn vẹn và chúng ta có thể tìm thấy cái phát hiện ra hội chứng Lynch sớm. Xin cảm ơn. Move on, question number 3. Trong trường hợp
để cô đọc
không đủ,
để cô đọc câu hỏi tiếng Việt. Thank you, Mr. Richie.
So if the case is less than 50 cells, how to handle the specimen or the situation? So this implies very, very small tissue, right? In a tiny biopsy, that's very possible to be encountered. And pathologists need to be judicious in our use of immunohistochemistry. To be honest, whatever limited specimen we have, we just have to make the most of it. And in case of MMR, this might really be the judgment call of the pathologist in discussion with the oncologist who might be wanting to do immunotherapy. Or they can discuss what to prioritize, right? But one way potentially would probably be to, instead of using the 4 antibodies, select only the 2, because if you notice, MLH1 and PMS2 always become abnormal together, and MSH2 and MSH6 almost always they become abnormal together. So you can select maybe just 2 out of the 4 in cases of limited tissue, like only MLH1 and MSH2, for example, as a priority. And then see because chances are if MLH1 is abnormal, almost always the PMS2 is also lost. So in these cases, although I would still recommend 4 antibodies for MMR, immunohistochemistry, but if I have limited tissue, I might just cut it to 2 antibodies. I mean, that's one possible way to manage. And then maybe to compare also if MSI might require less at the MSI process, like sequencing, so that if that's an alternative that could be considered. However, to my understanding, sequencing also would require a substantial amount of cut sections. So at the end of the day, when it comes to limited tissue, I will discuss it with the oncologist to help me prioritize what antibodies and what immunohistochemistry or molecular testing I should do. That's what I will do. So I hope this is not encountered a lot with solid tumors. Like colorectal, for example, usually the tissue sizes are quite big. So it's very case to case. Yeah, case to case basis, the way I would manage it. Yeah.
Cảm ơn câu trả lời của cô Richie. Câu trả lời là trong trường hợp mà mẫu sinh thiết rất là nhỏ và chúng ta không có đủ để chúng ta thực hiện 4 mặt cơ thì chúng ta hãy chọn 2, ví dụ như là LH1 và MS2. Như vậy chúng ta có thể xác nhận có mất biểu hiện của 2 mặt cơ này hay không, thì và chúng ta cần phải liên hệ với bác sĩ ung thư học để biết xác định xem là thật sự chúng ta có cần 2 hay chúng ta phải nhất định phải làm 4. Nhưng tôi vẫn khuyên là chúng ta nên làm 4 mặt cơ. Và trong trường hợp khác thì chúng ta có thể nghĩ đến việc chúng ta sẽ làm sequencing luôn mà chúng ta sẽ không có dùng 4 mặt cơ. Nếu như trong trường hợp mà có thể chúng ta tách chiết DNA từ sequencing sẽ đủ cho 4 cột DNA cùng lúc luôn, chúng ta không cần phải làm 4 mặt cơ như vậy, thì chúng ta sẽ cân nhắc là khi nào chúng ta sẽ chọn cách này và cách khác để cho phù hợp. Nhưng mà tôi vẫn mong là trong nghe nhất là trong cái trường hợp của ung thư trực tràng chúng ta nên làm 4 mặt cơ hơn là chúng ta làm 2 mặt cơ. Xin cảm ơn. Please move on to the next question.
Well, by the way, I want to add to the number 3 question. One thing pathologists have to remember when it comes to decisions on assay or whether it's immunohistochemistry or PCR, for example, and we have limited tissue, we discuss with the oncologist. And there is if the patient, depending on the patient, will the patient be amenable to another biopsy? If that is not an option, another option would be, for example, liquid biopsy, where they will, where the oncologist might resort to ctDNA and subject it to NGS to see and see for MSI along with tumor mutational burden and other mutations, and see if there is a targetable mutation or to make a decision with immunotherapy. So exploring other testing options together with the oncologist will be one approach. So that's what I wanted to add for number 3. Now for number 4, which region should be selected for TMA? The poorly differentiated or the deepest infiltrated region? To be honest, I don't have a good answer for this. I think either of the two will be okay. I don't have that much experience with selecting areas for tissue microarray. I would go for the invasive area for sure. And whether it's poorly differentiated or well differentiated, I'm not so sure. I probably will have to defer this question and to someone more experienced in colorectal cancer. For the number 4 question.
Okay, thank you for your answer. Với câu hỏi số 3 thì cô xin tiếp tục trả lời như thế này. Có thể là mình sẽ phải xin thiết thêm cho bệnh nhân trong trường hợp là không đủ mẫu. Chúng ta sẽ bàn bạc như là cách nào có thể sẽ thay đổi kỹ thuật. Chúng ta sẽ không phải dùng sequencing, chúng ta thay đổi như là ctDNA và NGS để mà chúng ta có thể phát hiện ra các đột biến của MMR luôn. Chúng ta sẽ không cần qua cái bước là 4 mặt cơ trên hormone miễn dịch. Tùy thuộc vào cái lợi ích của bệnh nhân sẽ được nhận được và cách bệnh nhân sẽ chọn cái phương pháp phù hợp với mình, với hoàn cảnh của bản thân. Tiếp theo là cái câu hỏi số 4 thì cô xin trả lời thế này. Cô cũng không có một câu trả lời chính xác cho cái câu hỏi này, cô không là chuyên gia về ung thư đại trực tràng. Có lẽ là mình cần phải cân nhắc thêm khi mà mình phải hỏi xác nhận lại cái câu trả lời này với một cái nhà chuyên về ung thư đại trực tràng thì họ sẽ chọn một cái vị trí nào nó phù hợp nhất. Please move on number 5 question.
Number 5, strong positive but focal, which is in this example is less than 10%. For some, they actually have a cutoff of 5% or less intense or weak than control tissue or the stroma cells, but diffuse, and how to explain. So it was mentioned in my talk, as per interpretation guide, if it is focal staining and we do not have a cutoff in our interpretation guide, so whether it's 10%, 5%, but it is intact in expression in an area of the tumor, by interpretation, we still call it intact expression. However, as a pathologist, we always put our interpretation in the context of the clinical background and the clinical scenario. So, for example, if there is any doubt as to why it is focal or whether or not there might be a staining issue, for example, as mentioned in my talk, the pathologist can choose to either repeat the staining in another specimen or confirm it with MSI or another confirmatory method like NGS. Same with the scenario where it is less intense staining, like weakly staining, but diffuse. Depends on how the weak staining looks like under the microscope. If it is really like weak, like as shown in my example in my lecture, very focal, very patchy, weak, I would call it loss of protein expression. And why it can happen, it can be, and sometimes it's hard to explain what might be the reason. But again, when in doubt, either repeat the staining or confirm with another method like PCR for MSI or NGS. I mean, in general, that's what I would do. Yeah. Okay, the other examples that I gave in my talk for focal staining is in treated specimens. If there's neoadjuvant chemotherapy performed, it is possible to show focal strong positive, but only a portion, let's say less than 10%. That's another explanation. So it helps to know the clinical background of the patient. Also, and then again, evaluating the tissue as a whole. How is the fixation process? Is the fixation even, or is the fixation adequate? Because incomplete fixation of the specimen in formalin can sometimes produce patchy staining or focal staining. That's another explanation. So it could be another cause of focal staining. So different possibilities could be pre-analytical, it could be treatment, pre-treatment, or it could be just the way it expresses itself in the tumor. Yeah.
Thank you for your answer. Câu trả lời của cô Richie là trong trường hợp dương tính mặn nhưng mà chỉ dưới 10% thôi, ngay cả trong trường hợp chỉ dưới 5% thôi thì chúng ta phải nên như chúng tôi đã đề cập trong bài của mình thì không có một cái ngưỡng cắt nào cho cái việc là bao nhiêu phần trăm chúng ta sẽ đọc là vẫn còn biểu hiện của MMR hay là mất biểu hiện của MMR. Như vậy thì trong trường hợp mà nó dương tính tức là còn không có mất biểu hiện của MMR kiểu khu trú thì nếu mà dương tính mạnh thì chúng ta vẫn tính là vẫn còn biểu hiện của MMR. Và trong trường hợp chúng ta nghi ngờ, tức là chúng ta đối chiếu bệnh cảnh lâm sàng của bệnh nhân và chúng ta nghi ngờ cái xác định này là không bị mất biểu hiện, chúng ta có thể làm lại một cách chúng ta đánh giá lại trên một cái lab khác, một cái block khác, hoặc chúng ta có thể xác nhận lại bằng sequencing. Và dĩ nhiên chúng ta phải nhất định là chúng ta phải đối chiếu với bệnh cảnh lâm sàng của bệnh nhân toàn cảnh của bệnh nhân như thế nào. Và Ở trong trường hợp mà nó dương tính 5-10% nhưng mà dương tính cái kiểu yếu, nhưng mà phải yếu là yếu như thế nào, ví dụ như là nó lốm đốm hoặc là từng điểm rất là nhỏ hoặc là rải rác, thì chúng ta có thể tính nó là âm tính. Tuy nhiên tôi nhấn mạnh rằng trong tất cả các trường hợp mà chúng ta nghi ngờ thì chúng ta sẽ xác nhận lại bằng cách là chúng ta chọn cái vị trí khác hoặc cái log khác để chúng ta nhuộm hoặc chúng ta làm sequencing. Và tôi cũng xin gợi ý một cái trường hợp mà nó sẽ dương tính kiểu khu ứng như vậy cho vấn đề về cố định và xử lý mẫu. Có thể vì cố định mà không hoàn toàn có thể làm được cái việc là nó sẽ dương tính chỉ có hoặc là còn biểu hiện chỉ có một phần thôi, và cái phần mà không được cố định nó sẽ bị mất biểu hiện. Đó là một cái trường hợp đó là mất biểu hiện giả. Xin cảm ơn. Please move on the next question number 7.
In endometrial carcinomas, can perform 2 markers instead of 4 markers, as in colorectal cancer or not, and which markers are selected? The recommendation is to use all 4 antibodies to complete the MMR panel, because there is a risk of missing an isolated loss of 1 MMR protein. So there are some who might economize and cut cost by using only 2 antibodies like MLH1 and MSH2 only, for example. But then what if only MSH6 is lost, or what if only PMS2 is lost? And that will be missed if only 2 markers are to be utilized. So by default, for all solid tumors, the recommendation is to use all 4 antibodies, preferably.
Xin trả lời câu hỏi số 7 trước, đó là trong trường hợp ung thư nội mạc tử cung thì chúng ta nên dùng 2, có thể thay thế cho 4 marker hay không? Thì câu trả lời là chúng ta không thể chỉ dùng 2. Ngay cả trong trường hợp chúng ta tính vấn đề kinh tế, chúng ta sẽ có một cái nguy cơ chúng sẽ bỏ qua tình trạng có biểu hiện của một trong 4 marker mà chúng ta không phân lập được. Vì vậy mà về khuyến cáo thì chúng ta vẫn phải làm 4 marker trên ung thư nội mạc tử cung. Please move on back to number 6 question. We'll just skip it, please.
Sorry, I'm sorry.
Sorry, Dr. Richie, please move back to number 6. We talked.
Number 6.
Yeah.
Could you please advise on the pitfalls in case of cytoplasmic staining, where tumor cell nucleus is strongly positive or weakly stained or not stained? If there is cytoplasmic staining, whether it's weak cytoplasmic staining or moderate or even strong, and you saw pictures in my lecture of cytoplasmic staining, ignore the cytoplasm. Just focus on the tumor cell nucleus. So I would just focus on the tumor cell nucleus and compare it with the internal control, which is the stromal cell nuclei. Ideally, it should be same staining as the tumors, as the stromal cell nuclei staining intensity, or darker. Now, if it happens to be very weakly staining, if the tumor cell nuclei is more weak in intensity than the stromal cell nuclei, I will be very careful in interpreting. And I will really double check my staining quality, and even the pre-analytical conditions of the specimen, and compare all 4 antibodies. Because if it's very weak, it, like in the example I gave in my lecture, it could, and it's focal, for example, in the tumor cells compared to the internal control, chances are it will be interpreted as a loss of protein expression. But again, I always say, just be careful when it comes to interpreting MMR in when it comes to staining that's not so straightforward. And when it's equivocal. So when the tumor cell nucleus is strong positive, I think that one clear-cut intact, right? Comparing it with the internal controls, that's also acceptable in staining. But if it's weakly staining or not stained, just double check, compare with the internal control, and to be sure that you can confidently call it loss of protein expression. This, that's what I would suggest.
Thank you. Xin dịch lại câu trả lời số 6 như sau. Trong trường hợp mà dương tính mạnh cả bào tương và cả nhân của tế bào U thì chúng ta sẽ đánh giá như thế nào? Nếu mà dương tính mạnh cả nhân tế bào U và bào tương của tế bào U thì chúng ta sẽ có thể là lơ luôn cái việc nó dương tính ở trong bào tương, thì chúng ta sẽ tính luôn là nó không có biểu hiện của MMR. Nhưng trong trường hợp mà tế bào U dương tính yếu ở nhân tế bào hoặc là focal U trú thì chúng ta phải double check, là kiểm đôi với tình trạng dương tính của tế bào mô đệm. Nếu tình trạng dương tính của tế bào U thấp hơn, tức là đậm độ dương tính thấp hơn so với tế bào mô đệm, thì chúng ta phải rất là cẩn trọng trong việc đánh giá cái trường hợp này là còn biểu hiện hay mất biểu hiện. Chúng ta phải kiểm đôi và chúng ta có thể là phải thận trọng làm lại và đánh giá lại một lần nữa, hoặc đánh giá những chỗ khác, những cái block khác, để chúng ta xác định xem là cái tình trạng focal này hoặc là dương tính yếu này là thực sự hay không, hay là giống như tôi đã nói trong bài ha, có thể là nó chỉ là một cái tình trạng không rõ ràng mà dương tính giả, và chúng ta sẽ không biểu hiện giả, và chúng ta sẽ có thể tính là nó phải âm tính. Cho nên phải hết sức cẩn thận trong các trường hợp này. Xin cảm ơn. At current state we have no more questions.
Các bạn có còn câu hỏi nào không ạ? Nếu không thì hôm nay rất là cảm ơn cô Richie đã tham gia sinh hoạt của hội giải phẫu bệnh thành phố Hồ Chí Minh với một cái bài báo cáo rất là chi tiết và chia sẻ những kinh nghiệm khi mà mình đánh giá cái MMR trên hóa mô miễn dịch. Thực sự ra thì cái ở tại Việt Nam đó thì chỉ có một vài cơ sở nhuộm cái này thôi, và chắc là cũng không phải tất cả mọi người đều biết cái cách đánh giá như thế nào cho đúng. Thì biết là nó dương tính trên nhân, biết là nó dương tính, nó mất biểu hiện ở một cái mặt cơ trên 4 cái thì nó là có bất ổn định vi vệ tinh lại mức độ cao. Nhưng những trường hợp mà nó không điển hình, nó dương bào tương rồi nó dương rìa vân vân, thì qua bài hôm nay thì đã giúp cho các bác sĩ giải phẫu bệnh ở Việt Nam hiểu rõ hơn về cách đánh giá. Cảm ơn cô Richie rất là nhiều, và hy vọng là cô Richie sẽ còn hợp tác để trong những cái buổi sinh hoạt tiếp theo.